Mr. Kramer, you're recognized.
Thank you, Madam Chair, and thanks to all of you. My goodness, I'm sitting here, as you know, I've sat here the whole time, and I've loved every minute of it because I see solutions. I have to agree with Ms. Eshu. She said, you look at the six of you and you find the solution to the problem. I was thinking about the Precision Agriculture Connectivity Act, and what would that task force that the FCC will set up should we pass this bill look like? I think it looks a lot like this, quite honestly. Because we do have competing technologies collaborating to create a ubiquitous network that's not reliant on any one of you, it's reliant on all of you and several others. And that's, I think, been both the opportunity and the challenge, that we do have competing technologies. We didn't have that with the interstate highway system. We needed a ubiquitous transportation system to move products to market and people from coast to coast, and so we have this very public highway system. When it was time to bring electricity to the farm, the REA did it beautifully, but there weren't competing technologies. Today, of course, there are more community-based power sources, things like that, but not at the time. But you all are in something where there's a lot of competition. And you're all in something that needs the product. How it gets there is not as relevant as that it gets there, right? So I think we have the makings of great collaboration among competitors. We hear a lot now today, of course, about satellite. We hear a lot about cable and fiber and fixed wireless and community-based, all of those things. And then we haven't talked a lot about mobile, but some, and not a lot about nomadic, but of course some, all of them together to get it there. But I want to ask you, Ms. Wood, as I hone in a little bit on the tremendous opportunity that I see in telemedicine in rural America. With 36 hospitals in North Dakota and still a lot of space between them. The bill we were able to do a couple of years ago, it allowed universal service funds to be used, for example, to connect nursing facilities, I think was a good step in the right direction. One of the things, though, we always hear about, and God bless Mr. Welsh for raising the fact that some of this does cost money, right? I mean, particularly in unserved and underserved and maybe profit centers, it requires some money, and we've provided some and more and probably need to do more. But at the same time, we often don't talk about the savings or the opportunities. For example, and this is what I want to get to you, in your testimony, you talked about that telemedicine, the benefit of it, the value of it. Has there ever been a cost-benefit analysis of people being able to stay at home longer, or maybe be in a community-based health center longer because they have a ubiquitous access to the experts somewhere else? Because we always talk about the cost, not necessarily about the savings.
I don't know about an official study. I'm sure they've been done. I know our facility and also Grand Run Hospital, the one that's 65 miles away, has looked at the number of miles saved. That translates to gallons of gas, the hotel rooms, the time off of work that, whether it's the patient or family members, don't have to take. Most of the savings, I think, is for the hospital and probably our primary care providers. They are able to assist these specialists. Often they'll do their visits side by side with the primary care provider in the room.
What I wonder, because you talked about reimbursement issues, right? And what's not allowable. And it would seem to me that we ought to take a real serious look at how, whether it's private insurance or Medicare in most cases, is reimbursing, how they might save by reimbursing something that they might not think is healthcare, if that makes sense.
Absolutely. Reimbursement is a huge issue, both for the originating site and the distant site. I'll tell you, we don't really even consider, for us being the originating site, reimbursement. We often don't even bill. We will, whoever we're working with on the other end, they pay us $25 per patient, a max of $100 a day. We could do 6, 8, 12 patients. We'll get $100. We're about the patient and what makes it better for them. And health-wise, they often feel better if they're at home and they're with their loved ones, their spouse, their children, more comfortable with being at home.
Excellent. And I'm just going to wrap up my last 10 seconds here with the Aggies. Thank you, John Deere. we haven't talked about unmanned aerial vehicles and the opportunity for imagery there and the ability to use. The beautiful thing about rural America, besides the fact that they grow enough food for the world, is that they do have a lot of available spectrum. It might be owned by somebody or licensed by somebody else or just not available, but it is available. If we can find ways to enhance the imagery, there's no reason we shouldn't be able to, to change the world with precision agriculture. And I know that you're all about doing that, and I've overstepped my time, Madam Chair.